Good morning. My name is Creighton Don. I'm with the University of Washington. I'm an interventional cardiologist, and it's my pleasure to talk to you today about intracardiac devices for stroke prevention, the heart-brain team. It's been exciting over the past 2 years that the FDA has approved 2 devices for stroke reduction that interventional cardiologists can provide for patients. In the cultural nomenclature, we think of the heart and brain as 2 ends of the opposite ends of a spectrum. The heart being something towards feelings, and the brain being something that gives us information about logic. Whereas to the point that we think of the heart and brain as opposites of each other. However, in medicine, we're finding that the heart and brain are perhaps more aligned than we'd think. We've traditionally thought about heart attacks, and now neurologists are talking about brain attacks. We perform percutaneous interventions for acute MIs, and now neurologists are preventing mechanical thrombectomy for strokes. We cool patients and take them for cardiac arrest to avoid neurologic complications, and neurologic complications can have an impact on the heart as well. And in fact, the heart and brain are perhaps more in line than we'd like to think. So how is the heart related to strokes? Well, strokes come from many areas, but 20% of them can come from a cardioembolic source, which includes atrial fibrillation, in which atrial clots form, which end up going to the brain, or clots form in the left ventricle, which can also cause strokes. There's debris that can form on valves that eventually make its way to the brain. And finally, there are venous clots that could pass through the heart through a patent foraminal valley and lodge in the brain, also causing a stroke. And of all strokes that occur, about 20% of them have some origin in the heart. So there have been 2 new devices that have been developed to reduce the risk of those cardioembolic strokes. The first being a device for left atrial appendage closure, and the second for patent foramen valley closure. I'd first like to speak about atrial fibrillation and stroke. Atrial fibrillation prevalence is important as it affects a great number of patients, and furthermore is increasing over time as patients get older. The prevalence in the US is approximately 2.7 to 6.1 million at present, and this will only increase as our population ages. And it is likely that atrial fibrillation is underestimated, given that it can be found subclinically in patients who had pacers placed who had no history of atrial fibrillation in 10 to 30% of them. And of these patients, there's an increased risk for stroke over 2-fold, even though there was no clinical diagnosis of atrial fibrillation previously. And in patients who are greater than 80 years old, approximately 20% of them have atrial fibrillation. And this leads to a 4 to 5-fold increase in the risk of stroke, which is similar for paroxysmal, persistent, or permanent atrial fibrillation, and is also associated with increased stroke severity. The attributable risk to atrial fibrillation also increases as patients are older. In younger patients, the attributable risk of atrial fibrillation to the occurrence of a stroke is in the 1.5 to 2.8 range. By the time the patient is 80 years old, the proportional risk of atrial fibrillation to their stroke is 23.5, which is quite high. Put it another way, if you think about patients who have no risk factors, the risk of stroke is shown below, less than 5%. If you add hypertension for men and women, it does increase your risk of stroke slightly, but by itself is not a major risk factor compared to adding diabetes or tobacco. But more importantly, once you add atrial fibrillation to these risk factors, you can see that the risk of stroke increases dramatically. Combining that with cardiovascular disease, and the patients have 20 to 25% risk for having a stroke. So how does the left atrial appendage relate to stroke occurrence? I'd like to start with a case. This is a patient I had, he's 7 years old, who presents with a stroke. And you can see here in the right occipital region, a large lesion that was found, an embolic stroke. Now this patient had multiple risk factors. He had hypertension, dyslipidemia, amyloidosis, renal insufficiency, cardiac disease with a myocardial infarction, reduced LV ejection fraction, and atrial fibrillation. And in the workup for this patient, looking at all the causes for stroke, the one thing that we found to cause this on an MRI, you can see here a clot in the left atrial appendage. As you can see here that the left atrial appendage is a more trabeculated, complex structure than the left atrium itself, which is smooth. As a result, in patients with atrial fibrillation, they can develop stasis of blood, and seen in this video on the right, spontaneous echo contrasts, which are early precursors to thrombus, and also thrombus forming into the left atrial appendage. Left atrial appendage anatomy may also be associated with increased risk for strokes, given appendages with more trabeculi or more small compartments may be more likely to form thrombus. What is the association with left atrial appendage clots and atrial fibrillation with strokes? Well, in patients who had embolic strokes, it's estimated that 75% of them come from a clot in the left atrial appendage. If you take patients with rheumatic atrial fibrillation, thrombus is found 57% of the time, and in non-rheumatic atrial fibrillation it's 91% of the time. On the right are shown studies in which patients were evaluated either by TE or surgery or an autopsy who had strokes and were found to have clots in their left atrial appendage, and in patients who had non-valvular atrial fibrillation, the vast majority of patients had clot in the left atrial appendage and not in the left atrium itself. There are several risk factors associated with this. There could be the number of lobes of the left atrial appendage, the shape of the lobes, the size of the left atrial appendage, the number of trabeculations, the velocity inside the left atrial appendage can also increase the risk for clot formation. And there's also a wide variety of patients with different anatomies. You can see here that there's a chicken wing type appearance, windsock appearance, and this may be more prone to form clots that might embolize. Interestingly, in patients who had a chicken wing morphology, that the risk of stroke was significantly reduced compared to a non-chicken wing morphology, emphasizing the fact again that morphology of the left atrial appendage may be associated with risk, a further way we can risk stratify patients other than the CHAD score. So what about anticoagulation? This is the mainstay for the treatment of atrial fibrillation for stroke reduction. Here are the therapies that we have available. In the study of warfarin versus aspirin and the study of aspirin versus placebo, we can see that there's a dramatic reduction in strokes when these therapies are given to patients. The use of the direct thrombin inhibitors, direct anticoagulants, show a similar reduction in strokes to Coumadin from placebo to treatment, placebo being the Coumadin arm. And these are very effective treatments. However, there are many patients who either do not or cannot take these therapies. This is a study of patients who are admitted with known atrial fibrillation who had an acute stroke. It was found that 30% of them, nearly 30% of them, were not on any therapy at all. A third of the patients were on therapy but were subtherapeutic. A third of the patients were not on anticoagulation but only on aspirin or other antiplatelet agents. And only 10% of patients were actually therapeutically treated. So there's a vast group of patients who are undertreated despite the effectiveness of these anticoagulation therapies. Thinking about this in another way, in patients who are able to take anticoagulation, only 50% of the time are they actually within therapeutic range, with a third of the time being subtherapeutic and about 20% of the time being supertherapeutic. And we know that patients who are supertherapeutic are associated with increased bleeding events, and patients who are subtherapeutic have increased embolic events. And warfarin is the number one cause for emergency hospitalizations due to adverse drug events. To reinforce the point about people being undertreated, this is a study from a HMO showing that amongst their patient population that patients with higher CHAD scores were less likely to be on anticoagulation, this so-called treatment paradox. Most likely these patients are at higher risk for bleeding or have poor compliance with medications and polypharmacy. And even patients who are able to be started on anticoagulation, after time, many of these patients discontinue this, despite the CHAD score. Even in the lower risk patients, that by 5 years, almost 50% of them have discontinued this therapy. So despite the best efforts of patients, even patients who are compliant initially with medical therapy of anticoagulation for atrial fibrillation, that it's a challenging medication to maintain over time. And again, our goal is to reduce strokes over the long term. What about the direct anticoagulants? Well, this is an interesting study showing that as these were introduced to the market, that the total number of patients who were anticoagulated remained roughly the same, and simply the patients who were already on warfarin anticoagulation were changed to patients taking direct anticoagulants. Furthermore, if you look at the compliance with the direct oral anticoagulants, that there is a compliance issue with this as well. These are the results from the clinical trials of rivaroxaban, apixaban, dabigatran, and edoxaban, showing that even in the best case scenario, in a clinical trial in which you have the most compliant patients and you have the best follow for patients, there's approximately a 20 to 25% discontinuation rate. So even in patients on direct anticoagulants, there's a challenge in maintaining this medication over the long term, despite their ability to take this initially in the time of the study. And in the real world, we see this again, although with vitamin K antagonists that the discontinuation rate is higher. 2 years after being started on a direct oral anticoagulant, patients have discontinued this 20% of the time. So what can we do to reduce strokes using left atrial appendage closure? There was a recently approved device called the Watchman device, which is basically a plug that can go into the left atrial appendage and seal it off and reduce the risk of clot formation in the left atrium. It comes in 5 different sizes. It's placed through a transeptal puncture. It's a fairly easy procedure. It can be done within 20 to 30 minutes. The patients are discharged home the next day. This is just showing the TE planning for this procedure. What we do is a transesophageal echocardiogram, and we measure the orifice diameters and length. At the time of the procedure, through a transeptal puncture, we can take some angiography and then the device is placed. It's showing the device being repositioned and the device finally released. Here's the device in place, and you can see how the highly trabeculated left atrial appendage is now sealed off by this device. There's no residual leak. And by 30 days, there's probably some endothelial layer that is formed on the device, and by 6 to 9 months, the device is completely endothelialized and scarred into the patient, and the risk for thrombus formation on the device is minimized. So what does the data show? There's been 2 major randomized trials looking at the Watchman device. In the first study, 707 patients were randomized in a 2-to-1 fashion to the Watchman device versus warfarin. These patients had CHAD scores of greater than 1, but on average the patients' CHAD scores were 2 to 3. The patients were randomized to Watchman. They were on anticoagulation for a brief period of time to reduce the risk of clot formation on the device, and they were also treated with antiplatelet agents. These are the main results of the study, showing that in terms of the primary endpoint, which is a composite of stroke or death, and the safety endpoint, shows that there was a benefit that favored the device in blue. That in terms of strokes, there was an overall reduction, but perhaps driven mainly by the hemorrhagic stroke reduction, whereas ischemic stroke reduction was slightly higher, although not significantly so. The surprising finding of this study that mortality was significantly reduced with this device, presumably due to reduced bleeding risk, but that was statistically significant. And the safety endpoint is shown here, that there were a few more safety events, primarily pericardial effusions at the time of the procedure and strokes at the time of the procedure, compared to warfarin alone. Here again, you can see that if you look at the causes of mortality, that hemorrhagic stroke was a large driver of this endpoint. And these are just showing those same endpoints with Kaplan-Meier curves. That in terms of the primary safety endpoint, after the initial risk of the procedure were accounted for, the device was superior to warfarin. In terms of the primary safety endpoint, this did not reach statistical significance over the time period that it was observed. There have been several studies looking at this device since that time. The pilot study that was initially performed, the PROTECT-AF study, the follow-up registry, the ASAP non-randomized study that is ongoing in Europe, the PREVAIL randomized study again, randomizing patients to Watchman versus warfarin among new operators, and the registry to follow up patients in that study as well, along with European and Asian registries and the Prevent US registry. There have been over 2,000, at this point over 3,000 patients treated with over 6,000 patient years of follow-up. So one of the concerns with this device were the early safety concerns. There were patients who had small perforations of the left atrial appendage, which led to pericardial tamponade. Also, there are patients with periprocedural strokes, presumably related to a clot forming in the device from patients who were not adequately anticoagulated, and there were episodes of air emboli. So this was the initial concern with the device, this 9.9% safety endpoint that was seen in PROTECT AF in the first half of the study. By the second half of the study, however, this rate had dropped nearly by half, and it's interesting and reassuring to see that over time, with the further registries and the PREVAIL study with new operators, and in that registry for the PREVAIL study, and in the European registry, the overall patients with the safety event at the time of the procedure has been on the decline, suggesting that there is a learning curve to using this device, and with better training that the safety of the device can be improved. In fact, in PROTECT AF versus PREVAIL in the later study, pericardial effusions were more than halved, from 4% to 1.4%, and periprocedural strokes were not seen at all in the PREVAIL randomized study. Looking at this, breaking it down further in terms of periprocedural complications, you can see that the highest rate of complications were in PROTECT AF, but in terms of things that we worry about, pericardial tamponade in blue, that this is reduced dramatically by the time we enter into the real-world use of this device. Things such as periprocedural strokes, procedure-related deaths, and device embolization are all much less than 1%. In the recent meta-analysis of the PROTECT AF and PREVAIL studies, we can see that there was essentially non-inferiority of all stroke. There was a concern that there's a maybe increased risk for ischemic strokes among patients getting the Watchman device, but this was balanced by the dramatic reduction in hemorrhagic strokes and major bleeding. If you look at the patients who had higher bleeding risks, that the benefit of the device was clearly favored, and patients who had lower bleeding risk, there appeared to be non-inferiority compared to warfarin. Now, if there's a concern about ischemic strokes, I ask people to turn to the DOAC studies. This is just showing meta-analysis of these studies, these showing a benefit compared to warfarin. However, if you look at the endpoints, that the benefit of ischemic strokes was not as dramatic as the benefit in hemorrhagic strokes. So again, a similar trend that you're seeing when compared to warfarin, that the greatest benefit that drives the benefit for these devices and for these new anticoagulants is a reduction in bleeding. So how would you compare left atrial appendage closure to other therapies we have for stroke reduction? Well, we know that warfarin works very well compared to placebo. Aspirin works somewhat better than placebo. And in terms of the other direct anticoagulants, compared to warfarin, there is a similar reduction in strokes. How does left atrial appendage match up to these? Well, at the 3.5-year follow-up, the rate of stroke was 5.6% in the treatment arm versus 8.2% in warfarin. And at 2 years, the rates are shown here, 3% versus 4.4%. And I would argue that this is in line with our other therapies for stroke reduction. Compare that to other therapies we offer for stroke reduction, such as hypertension reduction. We can see that left atrial appendage closure offers similar reduction in stroke rates. Compare that to other things we have, such as primary prevention using aspirin, or primary prevention with statin medications for cholesterol reduction. We can see that left atrial appendage closure for atrial fibrillation clearly has a benefit for a subgroup of patients. Looked at in another way in terms of absolute stroke reduction, comparing the SPAF studies, the SHEP studies versus all the other direct anticoagulant studies compared to the PROTECT AF study, we can see the PROTECT AF study, in fact, has at the very least similar reductions in stroke, if not better, than these other studies. And if you compare the predicted rates of stroke, if patients had been on no therapy, we can see that the imputed stroke risks were 2 to 3 times higher in patients if they had not been on any therapy at all. And again, I think this is a target area for patients for left atrial appendage closure. Patients who could probably take short-term anticoagulation, as I showed in that graph, who by 5 years are not on anticoagulation for one reason or another, we can offer them a therapy for stroke reduction by closing their left atrial appendage. The Has-Bled score is very important here. As I showed in the meta-analysis, the patients who benefited most from this device were the ones who were at higher bleeding risks, and the main benefit for this device compared to warfarin was a reduction in hemorrhagic strokes and major bleeding. So I think considering a patient's bleeding risk is highly important and informative for determining which patients are appropriate for this therapy. A hypothetical example would be a patient who has a CHAD score of 3, who has a Has-Bled score that's fairly low. And you could argue that their risk of stroke versus their risk of bleeding is almost equivalent. And of course, with stroke being a major life-limiting complication, that one could argue to accept this small risk of stroke, a small risk of bleeding to reduce the risk of stroke. However, if a patient has an almost 9% risk of bleeding compared to a 3% risk of stroke, one could argue that we can reduce this risk of bleeding and reduce the risk of stroke with the Watchman device, and this would be an ideal patient for this. What's more important is that patients with Has-Bled scores of 3 or higher tend to have real-world bleeding risks that are higher than predicted by the model, which has led to clinical practice of looking at patients with Has-Bled scores of greater than 2 to be candidates for this therapy. So in clinical practice, in patients who have difficulty maintaining anticoagulation, in patients with high bleeding risks, such as older, frail patients with multiple comorbidities or polypharmacy with bleeding risks, or younger patients with a long-term benefit from stroke reduction who have a lifetime risk for bleeding, perhaps due to their lifestyle or other issues in their life, they may perhaps benefit from left atrial appendage closure. And finally, as a rule of thumb, patients with CHADS-VASc scores of 2 or greater, which were the ones looked at in the PROTECT-AF and PREVAIL studies, or high Has-Bled scores of 3 or greater, are most likely to benefit from this therapy. We'll now switch gears and talk about patent foramen ovale closure, another intracardiac device to reduce strokes. The association of PFOs and strokes has been long studied. Again, the thought being that clots that can form on the right side of the heart or in the venous structures can go into the heart and cross through the patent foramen ovale, go to the left heart, and cause a stroke. It's interesting to see that although PFOs are present in about a quarter of the population, if a patient has a cryptogenic stroke, there's a 40 to 50% chance that they have a patent foramen ovale, which is a very interesting association. In a meta-analysis of case-control studies evaluating the association of stroke and PFO, it was found that if a patient had any stroke, that their risk of having a PFO was increased. If they had a cryptogenic stroke, that they had a 3-fold risk in the chance of having a PFO. And if they have a PFO with the atrial septal aneurysm, that their risk for recurrent strokes was an odds ratio of over 20. And if you look at patients who are younger than age 55, that the risk for having a PFO and the risk for recurrent stroke is very high in these patients. So some may say this is just a hypothesis, and I would agree that we don't have exact causal data that this is what's causing the stroke. But clearly, there are patients such as this one who presented with an acute stroke, who was found to have a clot not only in the brain causing the stroke, but still caught in the PFO here that's floating around in the heart. So clearly it can happen where a clot from the left side or the right side in the venous structures can cross the PFO and cause an embolic phenomenon on the left side. Right to left shunting of venous thrombus is a real-world phenomenon. In a study of 60 patients with pulmonary emboli, MRIs were performed in these patients, and it was found that 6 of these 60 patients had acute emboli seen on MRI, even though this was not clinically diagnosed. 33 of patients who had a PFO had emboli. So of the 15 patients with a PFO with a pulmonary embolus, 5 of them had emboli going to the brain. If you look at the patients without PFO, only 2.2% of them had an embolus going to the brain. So there's a strong association between the presence of a PFO and occurrence of a stroke. In other words, if you had a brain embolus, 83% of the time, you probably had a PFO. So yes, although this is an association, I would argue that it's a very strong association. And in the 4 studies that we will discuss, the RESPECT, CLOSE, and RESPOND studies, as well as the CLOSURE and PC studies, we'll see that there's strong evidence suggesting that closing the patient foramen ovale results in a reduced risk for recurrent strokes. This is just an animation below showing how the patent foramen ovale is closed. It's a minimally invasive procedure. It's a 1-day procedure performed with the patient awake through a transvenous stick. Takes about approximately 20 to 30 minutes. The PFO is crossed, and the device that has 2 discs, one that seals it on the left side and on the right side, and comes together, is released and closes the PFO. So I want to go over the 5 studies looking at device closure and the results on recurrent strokes. All these studies look at patients who have had strokes with PFOs. In this particular study, 909 patients were randomized 1-to-1 to closure with the StarFlex device versus medical therapy with aspirin and or warfarin. And we can see here that there is a trend toward benefit for closure, although it did not reach statistical significance. There were concerns about complications with the procedure, such as atrial fibrillation and vascular complications. However, in terms of the major complications, such as stroke, TIAs, or death, there was no difference in the periprocedural period. In the PC study, there were 414 patients with cryptogenic stroke who were less than 60 years of age, who had a PFO on TE, who were randomized to closure versus medical therapy. You can see here again a strong trend toward benefit in the PFO closure group in terms of reduction in strokes. However, this did not meet statistical significance either. In this study, there were similar rates of complications in terms of atrial fibrillation, major bleeding, TIA, strokes, and death at the time of the procedure. As a result of these 2 studies, there was a lot of skepticism about the benefit for PFO closure in these patients, leading some to even say, take an aspirin and call me when you prove it works. And I'd argue that we've proven that it works. There were 3 major studies recently published in the New England Journal of Medicine that shows a clear benefit for PFO closure. The first is the long-term follow-up of the RESPECT study, in which 980 patients with cryptogenic stroke that were imaging verified were randomized to PFO closure versus medical therapy. All patients were less than 60 years old at time of randomization and had a PFO on TE. In the intention to treat cohort, there was no benefit seen in the early study. However, as treated cohort, there was clear significance in the patients who had PFO closures. In terms of atrial fibrillation, you can see that the rates were extremely low, with PFO closure only 0.2% and major bleeding 0.4%. And these were similar to the patients in the medical therapy arm. When you look at the long-term outcomes, all the p-values become significant, both for the primary endpoints and recurrent strokes of undetermined cause. You can see that in red with a medical therapy arm that there are more events in that group than patients with their PFO closed. An extended follow-up, particularly looking at patients less than 60 years of age, there's a dramatically significant benefit. This sensitivity analysis was performed because patients who enrolled in the study who were younger than 60, who were older than 60 at the time of follow-up, were excluded. If you look at only the younger patients, that there's also a dramatic benefit for closure versus medical therapy, which were statistically significant. Patients who had anatomical features that were suggested of higher risk, such as an atrial septal aneurysm or a large shunt, also benefited dramatically from PFO closure. There's also the REDUCE study using a different device, in which 664 patients were randomized to PFO closure versus medical therapy. Similar to the RESPECT study, we can see that there was a very strongly statistically significant benefit for closure in the PFO group at 5 years. And finally, in the CLOSE study, which is an open-label study of different devices used for PFO closure versus anticoagulation or aspirin, that the reduction in stroke was dramatic with PFO closure. Again, this is looking at a high-risk population with a large shunt or atrial septal aneurysm. One of the biggest concerns with PFO closure are the periprocedural complications. And I'd argue that the risk for periprocedural complications such as atrial fibrillation, major bleeding, residual shunts are extremely low. And compare this to the reduction in stroke, I think that the risks outweigh the benefits. It is important to note that in the RESPECT study, they had a very low rate of atrial fibrillation compared to slightly higher risks in these other studies, suggesting a potential device association. The RESPECT study used the St. Jude PFO closure device, whereas the Gore Helix device was used in these other studies. And the NMT device, which is no longer available on the market, was used in the closure study. Potentially, there's a device-related benefit for reduced risk for atrial fibrillation. So what does this mean in conclusion? That the FDA has approved this, that we have 3 randomized studies showing clear benefit for PFO closure in young patients with atrial fibrillation, young patients with cryptogenic strokes. And so there will be a clear group of patients who will benefit from this that we need to identify and we need to treat for this condition. The rates of recurrent cryptogenic strokes are low, such that counseling of the patient is important, that you need to discuss the risk and benefits of the procedure versus medical therapy, that there's a chance that if the patient gets no PFO closure, they may never have a stroke through their lifetime given the low rates over time. However, that there are certain benefits for patients, particularly if they're younger, if they have atrial septal aneurysms, large shunts, and no other risk factors. The ROPE score is one way of helping to risk stratify patients. Essentially, it's a score which determines the number of risk factors for strokes other than the PFO that the patient has. And the fewer risk factors the patient has for stroke outside of the PFO, the more likely the PFO caused the stroke or is associated with the stroke. So the ROPE score is based on the prevalence of hypertension, diabetes, smoking, stroke, and age. And you can see that the higher the ROPE score, the more likely the patient had a PFO associated with their stroke. And even though their rate of recurrence is quite low, the stroke reduction is most likely going to benefit this group of patients. However, if the patient has a low ROPE score, meaning that they have other risk factors such as vascular disease or diabetes or they're a smoker, then their risk of having a stroke is high, probably driven by these other risk factors, and are less likely to benefit from PFO closure. So the future directions, I think the number one thing is that we'll have heart-brain teams in which neurologists and cardiologists will be working together to identify the correct patients for these therapies and to optimize therapy for them. We need to have more collaborative decision-making between neurologists and cardiologists, as neurologists can help provide the accuracy of the diagnosis. There are several patients who presented to my clinic who had unusual neurologic findings that turned out not to be strokes at all. So I think the accuracy of diagnosis is important in determining if a patient has a cryptogenic stroke or not. We need to weigh the other factors, the other risk factors for strokes other than cardioembolic phenomenon compared to the benefit you might have from left atrial appendage or PFO closure. And taking these things into account with the neurologist input, we can help weigh the relative benefits of medical versus device therapies. And the cardiologist input with regard to the anatomical risks for left atrial appendages or PFOs to cause strokes, to be able to assess the technical feasibility of the procedure, and finally to evaluate other causes for cardioembolic sources will be helpful in determining the risk and benefits of therapies for these patients. So in summary, Aristotle probably put it best when he said the seat of the soul and the control of voluntary movement, in fact, of nervous functions in general, are to be sought in the heart, and the brain is an organ of minor importance